Okay, so I think we'll get started now. First of all, I just want to thank everyone for joining us. My name is Ida Fernandez. I'm the Executive Director for the Imagine Spore Network. Welcome to today's session. This is our fourth installment in our network's monthly training webinar series. And these webinars are really aimed at building capacity and improving the design of future research studies. So we're really excited about today's talk on patient-oriented research and patient engagement in research, presented by our network's patient engagement working group co-leads, Dr. Deborah Marshall and Sandra Zielinski. First of all, I just want to go over a few housekeeping items before we get started. So please just try to keep yourself on mute throughout the presentation so we can minimize the background noise while our presenters speak. We will have 15 minutes allotted at the end of today's webinar for Q&A. So we encourage you to type in your questions using the chat box at the bottom of your screen or at the side of your screen, depending on what format you have there. And you can type in your questions any point throughout the presentation, and then I'll read them out to our presenters for them to answer at the end of their presentation. Following this webinar, you'll receive a link to complete an evaluation survey. So please give us your feedback so that we can continue to improve these sessions. And it also allows us to track participation for those that are seeking CanMed credits. Finally, we do record these sessions. We archive them on our website so you can view it in the future. So please visit imaginespore.com if you'd like to view again the webinar, share it with your colleagues, and you can even check out previous training sessions that we've held as well. Before we get started, I just want to introduce you to our presenters today. First, we've got Dr. Deborah Marshall. She was recently appointed as the Imagine Spore Network's co-lead investigator, and she's the co-lead for the network's patient engagement working group as well. She's a professor at the University of Calgary's Department of Community Health Sciences and Department of Medicine. She holds a PhD from the School of Public Health at the University of North Carolina, Chapel Hill, as an Alberta Heritage Foundation for Medical Research Scholar, a Master's of Science in Health Services Research from University of Alberta, and a BSci in Biochemistry from U of T. Her research program is focused on assessing the value of healthcare interventions through measurement of patient preferences, cost-effective analysis, and simulation modeling of healthcare delivery systems. She also holds the Arthur J. E. Child Chair of Rheumatology Outcomes Research and was a former Canada Research Chair in Health Services and Systems Research. So our next presenter is Sandra Zielinski. As I mentioned, Sandra is the co-lead with Dr. Deborah Marshall for the Imagine Spore Patient Engagement Working Group. She has been working as a patient engagement researcher for the past 7 years. She's a graduate of the Patient and Community Engagement Research Program, that's the PACER program at the University of Calgary, which is an innovative program used to train patients to design and conduct health research. Sorry, my screen keeps tapping out here. She's passionate about bringing a collective patient voice to health research and healthcare, and she's currently working as the lead patient research partner for the Alberta Spore Support Unit Patient Engagement Platform and is the project lead for the IBD Partnerships Project. She's been living with Crohn's disease for 27 years, and it is her lived experience that motivates her to work in patient-oriented research. So thank you to Deborah and Sandra for presenting today, and I will pass it over to both of them for today's talk.
Great, thank you, Ida. Can you hear me, first of all?
Yes, we can, we're good.
Good, excellent. Next slide, please. So as required, here are our disclosures. Next slide. The other thing is that because this is a CanMed's presentation, these are the roles that this fulfills with respect to that requirement. I won't read through all of these, but you can specify these they're specified on the slide. So, our learning objectives today. So first of all, really excited that there's so many people who signed in today. Welcome, glad you're interested in this area, because obviously Sandra and I are very interested in this area. And what we plan to do today are 4 things. One, to give you a bit of an overview around patient-oriented research, or we sometimes say POR, and then also patient engagement in research and differentiate them. Talk a little bit about approaches and opportunities to engage patients as partners in research. And I really hope that at the end of this, all of you can think of ways that you can do this in your own setting, in your own context. Talk a little bit about the benefits and challenges of patient engagement in research, and then finish off with a little probably a COVID motivated section, which is about how do you do virtual engagement in research? Next, please. So let's start with this saying. Oh, sorry, it's Imagine. I understand from Ida that not everybody is from the Imagine network on this webinar. So just very briefly, Imagine is one of the 5 chronic disease networks in the CHR SPORE initiative. And really it's looking at the interactions between inflammation, microbiome, diet, and mental health. And we focus really on IBD and IBS. And there's a nice graphic here that summarizes the idea of these relationships. So there's 17 hospitals and universities, which includes researchers, patients, clinicians across Canada, all with the mission to transform the management of IBD and IBS and associated mental health issues with those disorders. Next, please. So let me start with this overview. Next slide, please. And you've probably heard this saying, and actually Sandra and I were talking, she was saying the history of this, and I didn't quite realize how far it went back. But nothing about us without us goes all the way back to 1990s, really used by the early disability group. And it's really become a phrase that's commonly used in patient-oriented research and patient engagement research, really saying that, you know, the people who have the condition and who will be affected by the health research should have a voice in shaping and designing and using and sharing that research. And that patients are important partners in recognizing their own lived experience and making a really important contribution to how we think about work in the area, how we go about our research, and also how we apply the research, which I think is really important. And if you look at the CHR definition and the references there around patients, it's really inclusive of people with the personal experience of the disease, either of their own or also as caregivers or people looking after people or interacting with people with those diseases. Next slide, please. Let me just give you a 30-second high-level international view of patient-oriented research. There are many examples, and I don't mean to only highlight these ones, but I'm highlighting these ones because they've been around and they're quite well known. But just to give you a flavor of, I'm going to say, system or national kind of initiatives in patient-oriented research. So the first is Involve, and one of the messages here also is this isn't really new, but I think it's really just coming into its full form now in 2020 and in the recent years. But the NIHR, which is National Institute of Health Research in the UK, actually established Involve back in 1996. So it's been around for a while. And the whole idea was to support active public involvement in the NHS, in public health, and in social care research. So it's a government-funded program, and it still remains one of the unique programs in the world. Keo Awatia is actually a New Zealand initiative that was established in 2011, so more recently, but still out there. and has been there almost 10 years, and PCORI, which is the Patient-Centered Outcomes Research Institute in the US. A similar kind of idea was created in 2010. So not new, but certainly still coming into its own right as an effort around patient-oriented research. Next slide, please. So if we think about Canadian context, I think all of you are familiar with SPORE, and if we think about the end point, I think the end point, we would agree, is about making sure that the right patients get the right interventions at the right time. And now let me just, next slide, talk about, well, how would we do that? Well, we can do that, and we can help facilitate that goal through patient-oriented research. And when we use that term, what do we mean is a whole broad spectrum of research that engages patients as partners, importantly, and focuses on what patients have identified as priorities and things that are important to them, and all with the aim of improving patient outcomes. And patient-oriented research is done in a multidisciplinary context. It's in partnership with the stakeholders, and we really also want to share the knowledge that's generated by this to improve our healthcare systems. I will tell you personally, I've done patient-oriented research for many years, but the engagement experiences that I have had through efforts like PACER here in Calgary have really changed the way I frame my research, how I approach the research, and how I think about the research. And I think this is really a whole culture shift in the way we think about our research. Next slide, please. So that was patient-oriented research, but then there's also patient engagement in research, obviously related, but a little bit different. And when we talk about patient engagement in research, what we're thinking about is meaningful and active collaboration. And it could range from the governance, priority setting, actually doing the research, and knowledge translation. So again, there's this whole range of different things in which patients can be engaged. And I'm going to highlight the fact that it should be meaningful and active. And this is a great, I think, picture or cartoon that sort of reflects the fact that people in patient-oriented research, if they're fully engaged, are active and meaningfully partnering with the research team throughout the whole process. Next slide, please. There we go. Well, why do we do this? So might be intuitive, and certainly to Sandra and I at this stage, it's very intuitive, but I just want to finish this overview with saying patients essentially are at the heart of SPORE and of patient-oriented research. They do have expertise through their lived experience, and it really is eye-opening as a researcher if you are open and listen to what patients have to say. I have had in my project experiences when I was working most directly with patients completely changed the research question because the reality is I wasn't focusing on what mattered. So it's been kind of an interesting journey, but also a very valuable and I think meaningful one in the sense of being able to shape and focus our work on things that matter, essentially. So the whole idea of having patients at the heart of patient-oriented research is that we must involve patients to make the research more responsive to patient needs. And I won't go through all the bullet points below, but basically, you know, we want to achieve benefits that matter to patients. We want to achieve good outcomes, which should be linked also to better quality of life. And we want to make active and informed contributions to research and improving our system. Next slide. I also want to just make the point, and I'm not sure if everybody, this sort of becomes clear when you're doing this, but there's a difference between patients as partners in patient-oriented research and being engaged versus as participants and subjects. And both happen. And Sandra is going to give us some examples using Imagine of what we've been doing that covers this whole spectrum. So people can be participants and subjects. They can be in our focus groups. We can interview them. They're participants in our cohort studies. So the main cohort study for Imagine is enrolling 8,000 patients across the country. So yes, they're participants and subjects. But in Imagine and in many other research these days, patients are partners. They're part of the governance, and in Imagine we have this. And they're also part of our team in terms of thinking about our research, improving our research, and also generating ideas for research and working with us throughout that whole process. Next slide, please. So now I'm going to hand over to Sandra, and she's going to talk about those examples and opportunities and approaches to engage patients. Thanks, Sandra.
Thanks, Deb. So yeah, I'm going to get into talking and providing some examples from the Imagine network of what this can look like. So how do patients become partners, what type of work they do, and sort of those opportunities that, that we've had from the Imagine network. So first of all, I just thought I would set the stage by talking about the partnership piece. One of the foundations to patient-oriented research is developing those relationships and that rapport amongst the team. Just like any team, it's important to sort of have that relationship to move forward and work better together. And this slide really also talks about if we're coming together as a team with various expertise, so bringing together the scientific knowledge of the disease and then the practical knowledge of living with the disease. And it helps to round out that perspective and bring the different perspectives together. And really that we come together with shared values, we acknowledge one another's expertise, and that we have mutual accountability for the work that we're doing within the research. So I would like to introduce you to some of Imagine's patient research partners. And we also have, last year, we have 2 groups of PACERs, so the patient and community engagement researchers who graduated from the PACER program. So on the left, we have the IBD national team, which they refer to themselves as the MOBs. That's Manitoba, Ontario, and Alberta, I believe it was, or British Columbia. Yeah, British Columbia. And they did a study, so this is patient-led, peer-to-peer type research. And they did a study looking at the psychosocial relationship between individuals with IBD and diet and food. And then below we have the Alberta team. So the IBD Alberta team, which they refer to themselves as We've Got Guts. And they explored what resources are important to IBD patients right after diagnosis. And then on our right-hand side is all the patient research partners that have been involved with Imagine. Some of us from the beginning, where we helped with the proposal and submitting for the grant funding opportunity. So I believe we're at, well, quick math, 16, 17, 18, 19 people, plus the PACERs who are also a part of the the Imagine network. So just to say that it's not just 1 or 2 patients a part of the Imagine network as partners. There's quite a few of us that are doing many different things across the network. And so we'll talk a little bit about the patient-oriented Imagine patient engagement. So some of our goals are to develop capacity for people to do this work. So we have various training opportunities, including the PACER program, which those last 2 cohorts were able to go through. We help to support and implement research, identify aspects of treatment and care, and setting new research priorities. And I'll come to this in just a few minutes because we have a new project in which we'll be we'll be working on fairly soon, because our 5-year funding with Imagine is coming up, so we need to make sure that we're on track with our priorities moving forward. Some of the contributions that the Imagine Patient Research Partners are currently contributing to are they provide guidance and direction to the Imagine network throughout the network, and I'll get a little bit more into detail about that. They ensure that we address the unique needs of patients and ultimately, hopefully, improve the quality of lives with those living with GI diseases. And then, like I said, we have patient research partners embedded throughout the Imagine network on the level of the governance, in working groups, as well as co-researchers and or even leading research projects. And so we'll get into more details about that. So this is just a quick snapshot of what Imagine's governance looks like. We have patient partners embedded throughout all the working groups, including as patient co-leads. Also, just thought I would mention, we also do have a patient research partner included as an equal member of our external advisory board, which isn't on this governance chart. So then we're going to start looking at some project examples. And again, we'll get into more detail. This is just a snapshot of some of the projects that the Imagine Patient Research Partners have been involved in and or are currently involved in. And we'll talk about some of the roles in the research cycle that we're contributing to. So this is kind of a little bit early on, maybe a couple of years ago, we started talking about how can we recruit more people to the, especially the healthy donors, healthy subjects to the Imagine network. And so some of the Imagine Patient Research Partners came up with this kind of creative idea in which we can maybe advertise on social media and post some posters in clinics before COVID, and a way to maybe catch people's attention to join the Imagine network. Not as patient research partners, but as patient subjects, because we're looking for people to donate their poop, obviously. So then we'll talk a little bit about a project that we've just wrapped up and now we're kind of into the implementation stage. It's a patient-led study with support from, Deborah, so an academic researcher, as well as Gail McKean, who's a qualitative researcher at the University of Calgary, and Ida. So what we did with this study to start with is we did a training session on qualitative semi-structured interviews. We had 10 of our patient research partners who attended that session, so that then we can sort of go out and conduct interviews across Canada, because we're dispersed across Canada, being a large Canadian network. And we then the patient research partners went out into their own networks and conducted semi-structured interviews. We gathered all the data. We have one of our patient research partners, Gail Bellissimo, who is actually a trained medical transcriptionist, so she did all the transcribing for us. And then we did a training session on data analysis, qualitative thematic data analysis. And so then Deborah and Gail and I sort of just put together a rough framework. We did a couple practice runs, and then the rest of the patient research partners actually analyzed probably 8 to 10 interviews each. And so we did the data analysis as a team, and then went through the data, identified themes, and came out with sort of the top themes from that project, which were convenience, experience, communication, and compensation. And the whole purpose behind this is because we have such a large number of people that we need to recruit for Imagine, 8,000 people, and we do have some dropout rate. We were looking at how we can increase recruitment and maintain retention over a 4-year period. Excuse me, I have a frog in my throat. Over a 4-year period for this Imagine study. And so these were some of the common themes that came out. And so now we have the job of looking at implementing and finding some strategies that can help increase that recruitment and retention. And I'm just going to take a drink because something is going on in my throat here. So just a second, sorry. Okay. So this is a new project, not quite, we have ethics approval, and we're just getting started. There's a couple streams to this project, and I'm gonna focus on the stream with the patient research partners. There's 2 of us that will be co-leading the qualitative portion of this stream. There's also a clinician side and more quantitative, which will be led by the PI, who's Dr. Laura Turgonic, and then Kim Daly and myself will be, we've already sort of put together the focus group guide and the consent form to submit to the ethics board at the University of Toronto. And so all of that's gone through. We will be gearing up to do some recruitment over the next couple of months, and then looking to, Kim and I will be co-facilitating the focus groups, probably sometime in January. Transcriptions will also be done by, again, Gail, who's, like I said, a trained transcriptionist, so she'll be transcribing all the focus groups. And then we'll be going through doing the thematic data analysis. And so this will be looking at mental health in IBD, and really sort of, you know, our part of looking at, like, are the GIs asking the question about mental health, and what kind of resources would be helpful for them, who would they like to talk about. So all of those aspects around the struggles of actually living with IBD day to day, and what that's like, and what would be helpful for the patients. I was going to say next slide, but I guess that's my job. Okay, I'm going to loop Deborah into a little bit of this discussion, because we have, this is the priority setting exercise that I was referring to earlier, which we have we're just getting started on. We have, in partnership with SysCan, we have Dr. Tony Otley, as well as other members from the Imagine network, who have already conducted a James Lind Alliance in IBD and pediatrics. I think from what I remember last year, they had the top 10 priorities at our face-to-face meeting. And so we have in IBD pediatric care, we have our top 10 priorities that came from that. Number 1 being, what are the causes of IBD? So Crohn's disease and or ulcerative colitis. And now as we move forward, as a network, and are looking to secure more funding to continue the work that we're doing, we want to make sure we're on the right track. So we as a network will also be doing a priority setting exercise, sort of a modified James Lind Alliance priority setting. And I don't know if you want to add a little bit to this, Deborah, before we move on.
No, I think we'll just keep going. Yeah.
Okay, sounds good. And then again, this is a project that Deborah is leading along with some individuals from the BC Sport Support Unit. So Sterling Bryan and I think Aaron Mihalik. I never pronounced her name wrong, I apologize. And also, I'm totally drawing a blank with, I know, Danielle Lavely, who's also leading from the BC Sport Support Unit. So really looking at kind of comparing, you know, if we are executing a research study and one side's research guided and the other side's patient guided, what will the differences be? You know, is there a relationship between the level of patient engagement and key research outputs? When it's patient guided versus research guided, are the results going to be different? And does that level of engagement make a difference? And these are some of the knowledge translation activities that have been done by some of the patient research partners with Imagine. So we actually have had 3 podcasts with Guts and Glory. one on mental health and IBD, one on actually with somebody with a lived experience of having fecal transplants as treatment, and what that's like, and that was done with Dr. Paul Moyetti. They were all in partnership with a clinician and a patient research partner with the lived experience. And then one just really on an overview of the Imagine network and SPORE and patient engagement. So if you are curious to hear more about Imagine, the Guts and Glory podcasts are a good resource. We also have one of the PACER cohorts, the MOB group that had their abstract accepted. And so this is their poster presentation from that. Our monthly, is it monthly or quarterly newsletter? I think it's quarterly newsletter that comes out from Imagine. And so, yeah, just a few bits and pieces of some of the things that some of the patient research partners have helped to contribute to sharing the knowledge coming from Imagine. And so we're going to go into part 3. We're doing good for time, I think, Deborah. So benefits and challenges of patient engagement in research. So we're going to talk, this is very quick. Deborah and I will provide a couple of perspectives, her from the academic researcher lens and me from the patient research partner lens. And Deborah, do you want to set the stage for this and take over?
Yeah, thank you, Sandra. So I hope that gave you a good sort of smattering, I guess, of projects. There are others, and we're happy to talk about them in more detail, but we did want to take a couple minutes here because and discuss, what are the successes, challenges, and maybe some of the myths around patient-oriented research and patient engagement research, because the reality is, I guess people like Sandra and I and many people on Imagine are a little biased towards the positive aspects of patient engagement research. And I'm also really thrilled. As I was listening, I'm looking at the list. It looks like we have several of our patient research partners on the webinar. So please feel free to jump in because you certainly have experiences to offer that people would like to hear. But just very briefly to say, on that absolutely positive success side, I would say it is possible to engage patients as equal members of the team. And not everybody, I think, has really had this experience yet. Because as I said, relatively speaking, this is fairly new, and it's a different culture and a different way to work. But I think it's pretty clear that it is possible to do so. And I think the consequences that we're beginning to see are that we can change the health system in ways that it's more patient-centered. We can do things in a better way. And I might also add, based on my experiences with working with our PACER team, particularly musculoskeletal disease, actually, but you can change things in terms of the process in a way that doesn't require a great deal of investment, but sometimes just needs a small change in the process of how things are done, and it can make a big difference. So I think there's huge opportunities here. Sandra, do you want to add anything on the successes side?
No, I mean, I think just from my experience of working in multidisciplinary teams with various researchers, I've seen, researchers kind of at the beginning of kind of starting this whole, getting into patient-oriented research with a curiosity and not knowing how that would go. And then it has changed their practice once they've gone through the whole process and we sort of realized the benefits to the research that I've heard some researchers say, I will never do research without involving patients as research partners again, because it's absolutely the way to go. So yeah, I think the only thing we need to do, and I know this is all in the works, we have a national public and patient engagement evaluation framework project that's being done. And so it's evaluating so we know the impacts or the outcomes. And I think that sometimes that hesitation from some researchers of like, well, really, do we need to involve patients? So we need some of that proof in the pudding, so to speak, to show that here's some tangible, outcomes and how it's contributed to the success of this project.
Yeah, and I can give a really quick example in Alberta, which I think was quite dramatic, and that's why I bring this one. There's the safe surgery checklist, and we involved our patients in trying to look at why our rates of following the safe surgery checklist weren't quite as high as we would like. And I won't quote the numbers here because I might not have the exact numbers correct, but that's not the point. We got our pacers to look at the process, and a really simple change that was made was that instead of giving the checklist for surgery to the clinical staff, the nurses, and who are busy doing so many other things when preparing for surgery, they actually gave it to the patients and families before they went into surgery. And the patients and families then knew what the checklist was, and before they were wheeled into surgery would say, have we done all the checks on the checklist? And our compliance with the safe surgery checklist went up dramatically. So that didn't cost much. It really wasn't a major intervention, but it had a major impact on our ability to comply with the checklist. So I would see that as a major success for having engaged patients and looked at things differently, and putting the responsibility in the hands of the patients to participate and engage in that process. But there are challenges. So yeah, there are traditional viewpoints, and it is a change in culture, so we have to do things differently. We have to build the capacity and have some training so that patients can feel comfortable as an equal voice on the research team. And there's also the issue, and I'm going to get Sandra also to talk to this, around compensations for patients and funding and sustainability to engage patients in patient-oriented research. And Sandra, just before she speaks, I'll also say we were involved with, and several of our pacers plus other patients were involved in developing guidelines at the national level with CIHR for compensation with patients. And there is a policy, SPORE was also involved, all the 5 networks, in putting this together to try and work with that. But Sandra, do you want to comment on this?
Yeah, I mean, it's a bit of a hot topic in this space. Compensation can really basically create a more equitable space and remove barriers for people to participate or to be partners in research. Without compensation, there's the risk that we have the usual suspects, so to speak, where, perhaps people that are retired and have the means and the time to be able to contribute their time. So if we want more diversity and inclusivity, then compensation helps to remove that barrier. It also creates that equal partnership. So if the idea around, if everyone else is being paid around the table and you're the only person that's not, then is that equality? So there's a lot of discussion around compensation. It's also something that really needs to be a discussion on a one-to-one basis with patient research partners that you're engaging with, because people are in many different circumstances. They might be on disability plans or a number of different reasons. It's just like, you wouldn't discuss somebody's financial life in front of a whole group of people in normal times, so why would you do that to somebody else? So really meeting people where they're at, and it's not a cookie cutter approach, so to speak. So, and then just for sake of time, we should maybe talk a little bit about the myths of, engaging patients is easy. All patients want to be engaged, and everyone else on your team will support this idea. So again, really, it's not a cookie cutter approach. Engaging patients can take more time because they might require training, they might require some time to get comfortable with people. many different reasons. Not all patients want to do this type of work, and or they may be engaged at various levels or have different time commitments that they can contribute to the work. And then again, not everyone will always be on board, but I just look at it as planting seeds. And if somebody kind of gets curious, or it takes a bit of time for some people to come around, then hopefully we can convert a few others along the way.
Yeah, and I want to say
so
from a research, oops, sorry.
No, go ahead.
I was just going to say, is from a research perspective, as enthusiastic as I am, because I've done this for a while, sometimes my colleagues are not quite as enthusiastic, and I think Sandra said it nicely, and they come around once they see it, but I think the experience isn't always enthusiastically embraced at the beginning. So as a researcher, you may have some challenges to convince your colleagues that it's a good thing and it's a really worthwhile effort to work with patients really closely. So, next, sorry, Sandra, you're going to finish up with the virtual piece.
Yeah, and we're like, we want to leave 15 minutes, so we have about 3 minutes left if we have 15 minutes of Q&A. So we'll just quickly go through this section of strategies for virtual engagement, seeing as, you know, I actually officially know what it's like to be a basement dweller. Welcome to my basement office. I think I live here, and I just commute upstairs once in a while and then back downstairs. So definitely different space and time we're in with this whole COVID. And it presents new challenges that we need to consider when doing research, whether it's with participants and or subjects, or with patient research partners. And so just one of the things to consider is around recruitment. If we're thinking about recruiting patients as subjects or participants, there's a lot to think about in how are we going to contact those people, and how do we maintain confidentiality and privacy issues, and then how we're going to write that up to submit it to ethics. And then on the topic of ethical considerations, you know, it's a little bit different when you're engaging with patient research partners because they're part of the team. But again, we want to still maintain, you know, an ethical relationship with people, considering we're meeting online and maybe they have people in the background that are listening in on conversations, and so many different things to consider. And then logistics. So with an Imagine, we've really had to shift sample collections, for example, or have sort of pivoted to a different approach. Again, contacting people and engaging with people online is also really shifted since this whole COVID-19 pandemic. And I'm just going to skip over to technology. So again, when engaging patient research partners and or participants, there's many features in the technology we use. Really great. You know, we have the chat box where we can ask questions. We have, you know, we can share screens, all these different things. But sometimes, for example, the chat box could end up being a negative space. So if you are conducting a focus group, as an example, or even a meeting where people are on camera and sharing ideas, and perhaps a couple of people are responding to those ideas in the chat box, maybe even with a little bit of a negative tone, it can really hamper that engagement where somebody feels uncomfortable now to talk because they can see what's going on in the chat box and they might feel attacked. Or so really just thinking about all those things. How are we using this chat box? Is it in a positive way? Creating some, you know, house rules, so to speak, even in the virtual space. And then creating safe spaces, even just talking to the people. Do you have someone in your house that is in the background that you don't feel comfortable, like sharing personal information? Perhaps encourage headphones so that they're the only person that's hearing the discussion, as an example. And that also speaks to the confidentiality and privacy issue. And then internet connections. I know what this is like. I kind of live in a rural area. Sometimes my internet is a little shady. I always call in on my phone, and then, you know, sometimes I have to turn my camera off. So I just let people know, because I don't want to come across as being rude if I have my camera off, because that is a part of being more engaging, is when you have your camera on. But there's times where it's just making me crazy, as well as the people on the other end trying to listen to my 10-second delay. So always be mindful of, you know, people's situations and requirements. And that's where we're wrapping up. We're 9:46, so we have 14 minutes for Q&A. I want to thank everyone for listening, and thanks, Deborah, for putting this together, working together on this.
Excellent, and many thanks to all our funding partners. It's a large team effort from lots of different centers, and thank you for participating. And looking forward to questions. I see, Ida, there's some in the chat.
Yes, that's right. So thank you, Deborah and Sandra, for your very informative and insights into engaging patients in research. So we do have a few, and you know, please again enter, if you haven't already, enter your questions into the chat box now, but we'll get rolling, and hopefully that'll give you some time to enter some more. So there's a really great question here, is like, how do you ensure that you're engaging patients from all demographics, all walks of life, a very sort of representative sample of a patient engaged patient partner?
Yeah, I'll maybe give it take a crack at that, and Sandra, I'm sure, has some comments too. This is a question that came up quite a bit in our work with PACER, actually, because it is a question. You know, there's patients who are very engaged, maybe who have a lot of experience in doing this kind of work now, and they're a little bit different than people who don't have those experiences. Layered on top of that is the wide range of demographics, and how do you bring people in and engage so you are getting a variety of perspectives. And the best advice, first of all, I would say I don't think there's a perfect way to do it, but the best advice I can give based on our experience is give yourself a good period of time with lots of different approaches to recruit and make it known that you're looking for patients to be engaged. So I wouldn't just have one recruitment mechanism where, you know, you send out an email, you know, to people who are active on their email at a university, for example. We use our support unit, our provincial support unit. We might advertise through pharmacies, for example, where a lot of people would be coming in and getting their prescriptions. We've advertised through foundations like Crohn's Colitis Canada, for example, or tremendous help. So through different patient organizations. We also use word of mouth. So you can snowball sample, where you basically ask people you do know who have been involved to talk to other people. So I would just try in a very conscientious way to use lots of different methods. It is possible. We've done training, for example, with groups of Indigenous people. We've done it with rural people because we use technology like Zoom, which does enable people to participate. So be creative, and lots of different mechanisms is probably my best advice.
And this question is sort of in the same vein, but do you feel that a virtual approach to recruiting patients may in fact be easier than a face-to-face? Would that provide more opportunities, to actually reach more patients?
Yeah. Sandra, do you want to take it?
Yeah, so like to just also jump off what you're saying, I think that recruitment, that's where you're starting. It's about creating a plan. I don't necessarily think it's easier, because it depends on the population that you're recruiting or engaging with. So for example, if we're looking at trying to engage the homeless population, then that's not going to probably fly through, you know, like the virtual space. And so various populations have different ways in which they engage. And so to also Deborah's point, I think the other thing that we need to be open about is working with people in the way that they like to work. So if you're working with Indigenous communities, there's a different approach and methods in which they work in research. And it's not about them fitting into our box. It's about opening up and, you know, we work together with their approaches and methods. And sometimes that requires more of a community engagement type approach as opposed to like quote unquote patient engagement where we're looking at individuals and trying to bring people in, where we might have a connector who is, you know, very much connected in their community, in the Southeast Asian community or the Indigenous population. And those people really are the ones that bridge that gap between, like, say, research and the community that they're from. So I think it really, again, it's not a cookie cutter, like not one way is better than the other. It really depends on the population, the community, the people that you're recruiting. Sometimes recruitment online works amazing. Social media, whatever. A lot of people are online, but not all populations are going to respond to that.
Yeah, and I want to also say, sort of along those lines, emphasize the idea of the flexibility. So virtually, we have strategic clinical networks in Alberta, and virtually on all the networks, we have patients engaged in those committees and those efforts to improve the health system. But our very first PACER group, we had a homeless person. And the way we recruited them was through the community centers. That was another place, and I didn't mention that earlier, but where we had recruitment, we had a homeless person. We've also had other people where we had to then adapt the system because, for instance, he needed a computer. Well, we needed to figure out how to provide him a computer so he could interact with his group. So this is the sort of, I guess, thinking about the environment of the people who you want to participate and essentially enabling them to be able to participate. So you need to be flexible and adaptable as you're going through that, if you want, particularly if you want that diversity and inclusiveness.
So have you ever used any translation or interpretive services to expand the diversity of the patient partners involved in your projects at all?
I have some experience with a project that I worked on where we were developing person-centered care quality indicators with Dr. Maria Santana, and we had actually community connectors, and so those community connectors actually facilitated the focus group. So we worked with the Latino community or Latina community, Southeast Asian community, and so we had people, so we really had to trust in those people because they were the ones who spoke the language, knew their community really well, and were the ones that would facilitate the focus group in that language so that we could work with them. So to understand, you know, what is person-centered care from a Canadian perspective, including all backgrounds and voices and that type of thing. So that's not a direct translator, like that wasn't their like profession as a translator, but we were creative in how we engage people with this, you know, within their communities, and that's partnering with people in research.
Just a couple more questions here as we're wrapping up, but how would you say, or is there value in involving patients in sort of much more basic science type of research and, you know, more lab as opposed to some of the health services research where patients have much more direct experience with? And if so, how would you know, what roles do you feel they might play in that type of research?
Yeah, that's a great question, which we've had before, and I wish I had a more you know, comprehensive answer to that. But I think it is more challenging in basic sciences. As you know, there's a long pipeline and development cycle to bring you know, research ideas from the bench into practice. I do think it's a bit more challenging and a little less direct. Having said that, I think it probably is really useful in thinking about the long term and the applications of the technologies that are being developed in the lab at the bench, to try to make sure that we're focusing on what's going to matter most to impact patients and affect the disease. So I think there's an opportunity there for kind of the strategic, longer term vision and shaping that research agenda in terms of where we should invest our effort most substantially.
Thank you, Deborah. And last question I have here is, do you feel it's necessary to provide training in advance for patient partners to participate as a partner of a team?
Sandra, you want to start that one? I have a comment, but you go.
Sure. I don't think it's necessary, because I think when it comes down to it, the reason we're partnering with people is because they bring their lived experience as their expertise or their knowledge set, and that's what we're kind of why we're partnering and learning from the individuals. But with saying that, I do think, with time it is good to have training to bring people kind of up to speed, to get them comfortable working in research. And so it doesn't need to happen immediately, but I think it's helpful to have that happen as people get involved in doing this type of work.
Yeah, and I'll add that I agree. I don't think it's necessary, because you want to be bringing in a range of perspectives and experiences. I guess the delicate balance there to think about is making sure that people feel comfortable and respected and listened to in the environment of doing that research. And I think what we've observed is that if patients have some familiarity, with the health system, which is a strange system if you've never worked in health, actually, and also with how research is done and how it's approached, and at least some context, I think it helps make them feel more comfortable to be fully engaged. So I guess that's the delicate balance. At the very extreme, one could say, well, if they become, if you spend a huge amount of training and time, then they're a little bit different than, the average patient all of a sudden. So I think it's a mix, and I think we want all different perspectives and bring those different levels, I guess, of experience and training into the discussion.
And so
I think it happens. Sorry, go ahead, Ida.
Yeah, just to kind of tie it in with this last question here. How do you avoid researchers sort of having patient partners just as a token in a group setting? So what would you recommend to ensure full engagement?
Yeah, that's a good question. Loaded, because it does happen. It's all about the intention and the sort of the belief system behind what you're doing. And so if you go in with the intention of, okay, here's the research I'm doing, who do I need at the table? Not like, oh my gosh, we need a patient partner, let's just get somebody in, and they might not even have the relevant lived experience, and we can check the box to say we have a patient research partner as part of the team, so we can get funding, and then we never talk to them again. So, there's definitely like opposite ends of the spectrum where there's, very bad tokenism happening. Again, it's all about like planting the seeds, and, at least, if hopefully they get somebody who will speak up a little bit and help them to sort of change their perspective and start working together with them. But yeah, it's really, I think that like these networks and the spore support units, the provincial spore support units, help to support researchers to do it better or do it right. So that, I think, as hopefully they're reaching out to some of the people that have that expertise or experience to help support the work so that they kind of get it right at the beginning and not scrambling and just adding somebody because they're supposed to.
Yeah, and I'll just add, I think you know, we talk about training of patients. We need training of researchers to understand how to function and work with patients and change the culture, and to be, you know, respectful and understand the potential role of patients as full partners in the research. And since this is a SPORE group, and many of you on the phone, or some of you may be involved, we're in the midst of, you know, looking at the patient engagement framework. There's an initiative nationally to include all of these principles, and there's an existing framework as well about how do you go about patient engaged research and patient oriented research in a way that's meaningful. And I think researchers need to be sincere and understand how important and potentially beneficial it can be to work this way. So I think there's lots of learning for researchers as well.
Absolutely. So thank you, Deborah and Sandra, for a wonderful presentation. You've raised a number of very important points that researchers and patients should consider as they partner to do research together. So again, I encourage everybody to complete the survey when you receive the link. We appreciate your feedback. And thank you, of course, to all our partners that make these webinars possible. So good afternoon, everybody, and take care.
Thank you.
Bye-bye. Thank you. Thank you, Sandra.
Thanks, Deb.
Bye, everyone.
Bye.